So for the second part, the clinical part, which is mine, I would like to start by disclosing my ties with the pharmaceutical industry. As you can see, I have received several grants that were paid to my institution, and I have also received some consulting and lecture fees. There is one other disclosure I have to make, and that is that I am a nephrologist, and I would like to apologize right now for any selection bias that you may encounter during the next 15 minutes. So what has been exciting at this year's ESOT? And I think one of the things that we have seen are several big trials. In fact, this meeting, we have seen presentations of the largest clinical trial that was ever conducted in kidney transplantation. And that was, of course, the TRANSFORM study. Now, TRANSFORM was a prospective study which evaluated standard immunosuppressive therapy consisting of calcineurin inhibitors together with mycophenolic acid versus reduced exposure to CNIs in combination with everolimus. And this trial used a novel composite endpoint of treated biopsy-proven acute rejection or an eGFR of below 50 mL per minute. And you can see the design here, so more than 2,000 patients were randomized to standard therapy in gray, or they received reduced dose CNIs with everolimus. The most important finding of this study is that everolimus with reduced CNI is non-inferior compared to standard immunosuppressive therapy. So here you see the primary endpoint of eGFR below 50 or treated biopsy-proven acute rejection. So this study, TRANSFORM, shows comparable anti-rejection efficacy and safety outcomes in this novel trial. And also very reassuring is the fact that renal function was not significantly different between the two arms, and I think that this really puts this novel immunosuppressive regimen on stage. I think we now have green light to give our patients reduced tacrolimus with everolimus. The second trial that we have seen presented here was Athena, which was also a very large study that was conducted in France and Germany. And unlike the TRANSFORM study, this was a 3-arm trial, but again, standard therapy consisting of CNIs with mycophenolic acid was compared to an arm consisting of reduced tacrolimus with everolimus or reduced cyclosporin together with everolimus. And also in this study, the experimental everolimus-containing regimens were non-inferior as compared to efficacy. But the good news is that using everolimus-based immunosuppressive regimens, there is a markedly reduced incidence of BK and CMV viral infection. So I really think that adding everolimus to reduce CNI may be beneficial to our patients. What probably is not beneficial is a late switch from a CNI to a sirolimus-based immunosuppressive regimen. And these are the findings of the 3C study maintenance therapy comparison. And as you may record, all these patients were treated with alemtuzumab with reduced CNIs, or they received basiliximab and full-dose CNI therapy. And then after 6 months, these patients were able to undergo a second randomization to either continue tacrolimus or being switched to sirolimus. And the primary endpoint was eGFR at month 24. Now, the main findings are presented here. So an elective switch from tacrolimus to sirolimus does not improve graft function. However, it does carry a risk as late conversion, so after month 6 from tacrolimus to sirolimus, adds a rejection risk of about 5 compared to continuing standard therapy. So how about improving organs? And one other main theme in this meeting has been improving organ quality. And one of the very exciting studies that we have seen here are the first trial in humans comparing static cold storage in liver transplantation with normothermic machine perfusion. And this was a study that was presented by Dr. Nasrallah from the United Kingdom, and basically they compared livers on ice versus livers that were perfused with this very sophisticated device. The primary endpoint of this study was the peak AST level as a surrogate for graft survival, and in addition, a number of secondary outcomes were studied, including early allograft dysfunction. And the main findings are presented here. So peak AST was significantly and about 50% lower in patients that had their livers perfused normothermically by the machine compared to static cold storage. And furthermore, early allograft dysfunction occurred significantly less if you had a liver that was perfused normothermically. So I think this really sets the stage for further development of this machine. Another and maybe simpler way to improve kidney function in this case was presented by Dr. Vey from the United Kingdom, and she presented the 5-year follow-up results of the REPAIR study in which live kidney donors were treated to short courses of remote ischemic conditioning prior to donor nephrectomy. And 5 years after transplantation, remote ischemic preconditioning turned out to have a benefit of about 5 mL per minute of eGFR. And I think this is a very simple, cheap way that may improve the quality of the kidneys we transplant. So how about biopsies? Well, again, many data have been shown on the biopsy and the power of the biopsy, and I should start with this one. This is work that was presented by Dr. Lupi from Paris. And what you can see here is the iBox. And iBox is a predictive model that is able to predict long-term graft outcomes. And this was a huge study that was based on 5,000 patients, more than 10,000 biopsies. And these patients were transplanted all over the world. And what he showed is that by developing this risk index, you were actually able to predict long-term allograft loss. And I think this is very important in 2 ways. First of all, it may help us as physicians to counsel our patients and to predict their long-term outcomes. And furthermore, I think these models should serve as the starting point of future trials aimed at improving long-term outcomes. Another study, and again from the Paris transplant group, was presented by Viglietti. And what he looked into was inflammation in areas of interstitial fibrosis and tubular atrophy. And by again studying an awful lot of biopsies, they were able to identify certain clusters that associated with antibody-mediated rejection or Tcell mediated rejection. And they very strongly find that inflammation in areas of IFTA may suggest chronic Tcell mediated rejection, as patients who had IFTA were more likely to have Tcell mediated rejection or BK virus nephropathy, and better HLA matching and proper immunosuppression actually prevented the development of IFTA. And I think this is a very new and important finding that we will hear a lot more about in the next few years. So what then about the treatment of antibody-mediated rejection? Well, one thing that has been around for quite some time is bortezomib, the proteasome inhibitor. And we knew from single center and uncontrolled studies that that may have a beneficial effect. But now, and these are data coming from Vienna, presented by Eskandari, was the first randomized placebo-controlled trial of bortezomib. So 44 renal transplant patients were included in this trial. They were all DSA positive and had histologic evidence of ABMR, and then they underwent treatment with placebo or with bortezomib. Well, the bad news is that bortezomib does not seem to work. And here you see the eGFR slopes of the individual patients, and the thick line in the middle is the median average eGFR slope of the people in the 2 arms, and absolutely no difference in eGFR decline whatsoever. Furthermore, there was also no difference in the MFI of DSA, so I think the conclusion should be that bortezomib may not have a great future in transplantation. So what may have? Well, this is another study, very interesting study, again presented from Vienna, and in this study they presented a novel antibody directed against C1s. BIF-009 blocks the classical complement cascade, and 10 patients, again with evidence of ABMR and DSA positive, were treated with BIF-009 and then followed over time. And what you can see here that the drug actually reaches the plasma, so the red line indicates the drug concentrations, and in the blue line you see the complement inhibition by this novel drug. So this drug is very effective in blocking classical complement activation. Very interestingly, in follow-up biopsies, the intensity of C4D staining was decreased after treatment with BIF-009, and I think this really is promising, as this drug may have a role in the future. And finally, a very exciting novel drug that has been used in SLE, belimumab, an anti-BAF or anti-BLyS monoclonal antibody, was tested by Manna Clatworthy. And these were 28 low-risk kidney transplant recipients that were randomized to receive placebo or belimumab on top of standard quadruple immunosuppressive therapy. The primary endpoint of this study was safety. There was concern that adding belimumab to standard immunosuppressive therapy would cause excess infections, but the secondary endpoints included all kinds of immunological endpoints. And the good news is that this drug does not seem to offer a disadvantage in terms of infection, but some very interesting observations were made in the immune system of these patients. as belimumab seems to reduce naive B cells and the number of plasmablasts, while it increases the number of interleukin-2 producing regulatory B cells. And moreover, the development of de novo antibodies, and these were not just DSA, was reduced in patients who received belimumab therapy as compared to placebo. So what about infection? Well, I'd like to show and highlight two centers. So this is another study coming from France, the TREV trial. And in this trial, the effect of raltegravir, an anti-HIV drug, was tested. And as you may know, the acute rejection incidence is very high in HIV-positive patients. Numbers of up to 40% have been reported. And unlike standard anti-HIV drugs, raltegravir does not seem to have a pharmacokinetic interaction with the immunosuppressive agents. And in this study, a nationwide study conducted in France, patients were included, and then they were treated with raltegravir after their kidney transplant, and then they were followed. And the good news is that using raltegravir in addition to standard immunosuppressive therapy, you get a very low acute rejection incidence, while the problems with HIV are very limited. And I think this is the first indication that raltegravir may become the new standard of care in treatment of HIV transplanted patients. So how about this other infection? Well, CMV remains to become a big problem. And these are very interesting data come from Bellvitge Hospital here in Barcelona. And in this study that was presented by Marta Jarque, more than 300 patients were tested for CMV-specific cell-mediated immunity. And this was done by using ELISpot against several peptides produced by the CMV virus. And then the Bellvitge group was able to identify patients that were at high, intermediate, or low risk of developing CMV disease and CMV infection. And I think this is promising, and I think assays such as this should become in our new therapeutic armamentarium to guide antiviral prophylaxis. And then finally, there have been lots of special issues, and I would like to conclude my talk with one. And one of the things that we, and mostly our patients, have been worried about is the use of mycophenolic acid and male fatherhood. Anders Asberg from the group of Oslo was able to combine the Norwegian nationwide data on kidney transplantation of all male kidney transplant recipients that were alive between 1995 and 2015. And they coupled that database with the birth registry of Norway. So once again, illustrating the power of big data. And then by doing so, they were able to identify 230 males that fathered 350 children in all. And taken together and looking at the birth outcomes of patients that were exposed to MPA and patients that were not, they identified absolutely no significant difference. And their conclusion, quite rightfully, was that mycophenolate is not a risk in fertile men. And I think that is a very hopeful conclusion, and that's where I would like to stop. And I thank you for your attention. Molte grazie.